Dr. Monty Cantor. I'm a board-certified orthopedic surgeon from Elmhurst, Illinois, who has been in the practice of orthopedic surgery in Elmhurst since 1966. I received my undergraduate training at the University of Virginia. I then got my medical degree also from the University of Virginia, graduating in 1958. I had 2 years of postgraduate training on the Harvard service at the Beth Israel Hospital in general surgery in Boston, Massachusetts, and then an additional 6 months in general surgery at the Boston VA Hospital, and 6 months of fellowship in orthopedics and trauma at the Boston City Hospital. I then had a formal 3-year orthopedic residency training program at the Albert Einstein College of Medicine, Jacobi Hospital in the Bronx, New York, finishing my training in 1964. I spent 2 years in the Army as an orthopedic surgeon at Fort Riley, Kansas, finishing in 1966 and coming to Elmhurst at that time. I'm licensed in the state of Illinois, but also have licenses that are enacted in the state of Massachusetts, New York, Virginia, and California. I received my board certification in 1968 and am a fellow of the American Academy of Orthopedic Surgery. I have taught at one point in my training at Loyola and Hines, with the Hines Veterans Hospital in the Chicago area, and have gone to Bolivia on 3 occasions to teach and do orthopedic surgery. I've taught residents here and there, but for the last 10 years, essentially, since I stopped doing surgery, I've been doing mainly medical legal consultation, reviewing records, giving opinions, 90% for the defense bar and 10% for the plaintiff's bar. I try to chronologically lay out records and try to help people understand the significance of the records at various points in time and what injuries are reasonable and what injuries are not reasonable. I have reviewed Mr. Roman's rather extensive records at the request of the defense attorney, Mr. Fox, and I've submitted a rather lengthy initial report which lays out the records chronologically. Unquestionably, in my opinion, Mr. Roman sustained a significant injury to his right tibia and fibula and his right foot. He sustained a open fracture of the right calcaneus, the os calcis, the heel bone, which fortunately did not extend into the subtalar joint, but did extend into the calcaneocuboid joint. The initial treatment was at a hospital in the area, but since they could not find a vascular surgeon willing to come in and treat Mr. Roman, he was medevaced by helicopter to Rockford Hospital, where his fractures were treated. Significant as to whether he had an injury to the posterior tibial nerve or not, I think is the fact that he did have an arteriogram which showed that the medial and lateral plantar nerves were patent, and so there was probably no initial injury to the region of the posterior medial malleolus where the posterior tibial artery and nerve lies. He certainly had a fairly significant soft tissue injury to his heel, which fortunately after a period of time did heal without infection. He had external fixata to his tibia. There was some question about whether the pin tracks were fully healed or not. And so even though there was an initial hope to do an intermedullary nail fixation of his tibia, this was not done. Dr. Walter Verkus at Rush, who is a traumatologist, a trauma surgeon, and an orthopedic surgeon, undertook the treatment of Mr. Roman, initially seeing him in November of 2010. The injury was on September 21st, 2010. Dr. Verkus elected to remove the external fixator and let the pin tracks heal for 3 weeks. Went back in, and after he had done that, went back in and replaced external fixators because he was still not safely able to do an intermedullary nail fixation. There was debridement of some local bone reaction consistent with local osteomyelitis, but fortunately all of that eventually healed without difficulty. In May of 2012, Dr. Verkus opined that Mr. Vroman was healed. He continued then to follow Mr. Vroman until early 2012, indicating really good progress, healing of the fracture, residual pain consistent with the fractures, but at no point was there any discussion or question or indication of a complex regional pain syndrome. As you probably know, most of us, particularly those of us that deal with trauma, are very much aware of complex regional pain syndrome and look for it as an explanation for atypical pain. However, in my training, atypical pain in and of itself is not sufficient to diagnose a complex regional pain syndrome. In March of 2012, Mr. Vroman was seen by a physical therapist to give him some work conditioning, and the physical therapist did not document any findings consistent with a complex regional pain syndrome and documented residual pain complaints that are easily explained by the fractures and the magnitude of the injury that he sustained. It would seem that the International Association of Pain Management sets up criteria for the diagnosis of complex regional pain syndrome. It's the same criteria that most of us are familiar with. There has to be sort of extreme and disproportionate pain. There needs to be allodynia, diffuse reaction to stimulation, such as just lightly touching the skin. There needs to be some change in the temperature, some change in the color of the skin at some point to make a diagnosis of complex regional pain syndrome. The only difference, according to the International Association for Pain Management, in type 1 and type 2 is that type 2 is associated with a nerve injury. Well, obviously, Mr. Vroman had injury to superficial nerves, particularly about the heel, but I don't think there is any objective evidence of an injury to his posterior tibial nerve. The difference between 2 and 1 is that 2 does not have signs of sympathetic overflow on a continuous basis, but at some point needs to have this. And I think it's obvious that well-trained clinicians that followed Mr. Vroman for months and who would have been attuned to complex regional pain syndrome did not make this diagnosis. The first suggestion of complex regional pain syndrome was on August 22nd, 2012, when he was seen by Dr. Laporta. This is now almost 2 years after the accident, and far too long to say at that point that complex regional pain syndrome is present simply because there may be pain on cupping the heel or some atypical pain complaints from time to time. Complex regional pain syndrome should not be relieved or should not be explainable by pain that can be due to other sources, arthritis, post-fracture pain, simply some sensory changes due to the fact that he had a significant laceration about the posterior aspect of the heel. Just because he has pain on cupping the heel in the region distal to the scar does not make this complex regional pain syndrome. You would expect this because of the amount of scarring he had. Had he had diffuse tenderness or pain response to palpation about the foot, this would be consistent with allodynia and complex regional pain syndrome. Complex regional pain syndrome should not be relieved by simple measures such as, in this case, Aleve. Aleve should not relieve complex pain due to complex regional pain syndrome, particularly if it's at a level claimed of 8 on a scale of 10. Local cream to the foot should not relieve complex regional pain syndrome, and the cream that was prescribed and compounded at the request of Dr. Laporta, consisted of only one thing that would work with pain, and that would be a 10% lidocaine pain cream. There was some ketoprofen, an anti-inflammatory in it. It also had gabapentin, but I don't know that this even works through the skin. But this gave Mr. Vroman relief, which should not have been achieved with complex regional pain syndrome. Orthotics should relieve complex regional pain syndrome. So we have in Mr. Vroman no objective basis of an injury to the posterior tibial nerve, and a electromyogram, which I think would have been indicated, was not done. We have changing symptoms. We have a positive Tinel's, and then we have a faint Tinel's. We have symptoms that are relieved by measures that should not relieve the pain from complex regional pain syndrome. So in my opinion, I don't think there's any indication in this case of a complex regional pain syndrome, and I don't think there's any indication, objective indication, of an injury to the posterior tibial nerve. I will put this in a report to summarize what I've said, but it really is nothing more than what I have said to try to summarize the records. Thank you. Not only did none of the doctors document or show concern for complex regional pain syndrome, but Dr. Levin, when he evaluated Mr. Vroman on May 21st, 2012, only documented pain at the level of 3 to 4, level of 10, which was about what the physical therapist noted in March of 2012. But there was no indication of changes consistent with CRPS. In July of 2013, Dr. Levin actually measured temperature to tenths of a degree and noted that the temperature was equal bilaterally at 77.4 degrees. Absolutely no indication on that examination, as documented by Dr. Levin, of complex regional pain syndrome. It was only later, when presented with Dr. Laporta's records, that Dr. Levin opined that the pain was consistent with complex regional pain syndrome. Again, I don't think there's any objective evidence of complex regional pain syndrome or damage to the posterior tibial nerve. Even Dr. Laporta only diagnosed complex regional pain syndrome on his initial visit. Subsequently, the diagnoses became chronic foot pain, and the diagnoses became arthritis in the right foot. Remember, part of the diagnosis of CRPS is there can't really be other reasonable explanations.